Welcome to the GOTA virtual conference. Scan the QR code on the left to participate in our silent auction. The silent auction will run from October 1st to October 29th of 2020. Scan the QR code on the right to go to the GOTA online store. Thank you to our 2020 sponsors. Platinum level sponsor, the Shepherd Center. Gold level sponsors, All About Kids Therapy Services in the University of St. Augustine. And silver level sponsor, Hanger Clinic. All right, our speakers tonight include Elizabeth Burch. She's graduated from Brenau University with a master's and an OTD. She's been working for 6 years in the acute care setting. And our second speaker tonight is Lisa Smith. Lisa graduated with a BS in physical therapy from Georgia State University and a master's in education from the University of New Orleans, a doctorate of physical therapy from Alabama State University. She has over 32 years of acute care and subacute care experience. So at this point, I will hand it over to our speakers for the evening.
Hi, good evening, everyone. Thank you for tuning in at 8:30 at night during a work week. We really appreciate it. Just let everyone know that we kind of set this up so that way we can have more of a dialogue at the end of the presentation with our hour and a half. So if you definitely have questions, please put them in the chat so you don't forget them. But we're going to try to get through our slides first so that way we can have that dialogue at the end. So as Kristen introduced, I'm Dr. Elizabeth Burch. I am an occupational therapist and I work at Piedmont Fayette Hospital here in Fayetteville, Georgia. This is Lisa Smith. We did not introduce who was different at the start. So tonight we're going to be talking about the Boston AM-PAC with you. Just to begin, we'll look at our learning objectives. First and foremost, we wanted to show that we had to create a common language among our team in the acute care setting. We want to show how this Boston University activity measurement can be used in the hospital setting, and also how it relates to occupational therapy services and how they're delivered in the hospital, which will ultimately help with our length of stay and our readmissions. So to give a little bit of background, like I said, we both work for Piedmont Fayette Hospital. The vision for our organization, as you can see, is our purpose, our promise is to make a positive difference in every life we touch. We are a 282 bed hospital. We are one of 11 in the Piedmont healthcare system. And we just found out we actually just received for the 6 consecutive years the American 50 Best Hospital Awards. So we are very proud of that. And what that award is for overall clinical experience. And why I feel like this is important, because we get to do things like this, present something that we found where there was a deficit in our hospital and how we were able to change that. So I wanted to connect our presentation today with the overall AOTA vision of 2025. The American Occupational Therapy Association has identified 5 pillars to facilitate participation in everyday life for all people, population, and communities. 2 of these pillars include leaders and collaboration within systems to produce effective outcomes that incorporate current evidence-based practice. The pillars encompass a customized occupational therapy service, which will be accessible to everyone and embrace diversity among all platforms. So at Piedmont Fayette Hospital, we're going to be talking about the different service lines. And what we have found is often we work in silos. When we work just in our silos, the 3 main things we have realized: there's a delay in discharge planning, increased length of stay, and decrease in patient satisfactions. So when I introduce the word service lines, within our hospital, we're including our medical doctors, our nurses, case managers, occupational and physical therapists. Here we determine at a system level, there was a decision we had to change our culture and focus on a common language for participating in everyday lives and functional mobility. So what we found, we as a department, as occupational therapy and physical therapy, we knew what we were talking about with ADLs and mobility, but we looked at how the whole person was, but not how the medication affects a person, not with a medical doctor. So we realized we were not on the same page for the whole patient's care. So we discovered, and Lisa will tell you about the timeline in a little bit, an assessment that we found that our nurses would also be able to complete, not just the therapists with the OT-PTs and also speech. So just a brief overview. The assessment is officially called the Boston University Activity Measure for Post-Acute Care, the AM-PAC 6 clicks. We are going to refer to it as AM-PAC from here on out. But the AM-PAC is a standardized test with high reliability and validity. It is based on activities based on the World Health Organization on the ICF model. So you'll see common words that you would see from the World Health Organization model. The AM-PAC can be used with all diagnoses and conditions, but some of the main ones that most of us are familiar with are the orthopedic neurological impairments. The AM-PAC provides information on functional impairments with mobility and ADLs. The AM-PAC also has been shown to have a high understanding for the initial predictions of discharge destinations. And really, the AM-PAC can help initiate discharge planning. So what is the AM-PAC? So the AM-PAC, we use the short version. There is actually 3 different AM-PACs. There is the one we have shown, the AM-PAC for ADLs, that identify the functioning of a person's being able to complete their ADLs. There is the AM-PAC mobility, which is a tool to help identify the level of mobility. The third one is the AM-PAC cognition. Our speech therapists did not like this assessment compared to some of the others, so this was not included. With the AM-PAC, it's very easy to score. You have a score from 1 to 4. 1 means you're a total assist. That person cannot do a thing at all. A score of 2 is at moderate to max. They need a lot of help. A 3 is the minimal assist, just a little bit of help, and they can do most of the tasks by themselves. And 4 would be the person is independent. They don't require help at all. But one thing that I do want to put out for a scoring of 4, you can use an assistive device. So what most of us therapists would think about be MOD-I, you would score under a 4. So this is literally the AM-PAC assessment tool for daily activities. As you can see, there's 6 questions. And honestly, this is what our OT evaluations going to include anyway when we're looking at ADLs with lower body clothing. And then bathing is lumped together with upper and lower body. Tooling, the tooling does not include the transfer. This is actually the task of donning clothes, sitting down, wiping, carrying out the whole aspect of toileting, but not the transfer. Upper body clothing, the 5th is grooming task, and the 4th is eating meals. So as you can see, those are the 6 basic questions, and the person would score in each quadrant. With scoring this assessment, you would have to answer all 6 of the questions. So the AM-PAC mobility. The mobility section, as you can see, just like the ADLs, there are 6 questions, and the scoring is exactly the same from 1 to 4. For example, the first one is just turning in bed. The second is sitting down and standing up from chairs with arms. A good one we use a lot is the bedside commode, so that's a perfect example to see. Moving from supine on the back to sitting on the side of the bed. The 4th is moving to and from a bed to a chair. 5 is to walk in a hospital room. How literally are they getting from point A to point B? And 6 is, would the person be able to climb 3 to 5 steps with a railing? So based on these scores, 6 is obviously the lowest. That means the person is completely dependent. To 24, the person is completely independent. So you do get a range with these scores, but what you do with each of the 6 questions, you score them and then you add the numbers up for a total. So 6 is definitely the lowest score you can have, and 24 is the highest based on that 1 to 4. So what does the score tell us? So the score tell us is the initial prediction of where this patient should go once they discharge from the hospital. This is all case dependent. We do have some of those outliers of someone who is bedbound dependent. So it is just a guide based on the prior level of function too. So those patients who are in those higher levels, discharge, as you see, from 22 to 24, based on using the AM-PAC scoring, the patient should be able to discharge home with no services like home health, anything like that. Score of 18 to 21, home with home care, such as home health. If a person scores 12 to 17, the recommendation would be for our acute versus subacute rehab. And then from 6 to 11, those patients would more than likely would be more appropriate for an LTAC.
So I want to discuss a little further our timeline and how we actually got the AM-PAC implemented here at Fayette and eventually at our system. About 3 years ago, our rehab director, Jill Fenimore, and I attended a continuing education conference, and we started hearing about the AM-PAC at our conference and thought it was a great tool that was easy to use. It was reliable, it was valid, and it was something that the nurses could actually use as well. We brought it back to our facility and we actually started implementing the tool in our rehab documentation. Later that year and into the early part of 2018, we wanted to present our AM-PAC tool to our nursing team and have them use it as their nursing admission screen to replace their current one, which at the time was 24 questions, but it did not generate any information for them. They did not know what to do with that information. They just answered the questions and they got their box clicked that they had done it. So we presented a proposal that, hey, let's let the AM-PAC become the nursing admission screen. And we presented that to all the stakeholders. This was at the system level, at our electronic medical record level, and this was to the leadership and the shared governance councils for rehab, for the executive staff, for nursing, and for the frontline nursing staff as well. So as you can see, that took over a year to just get on their agenda, to meet with them, to pitch our tool, and to make sure that they understood what we were asking and how it would benefit the nursing team and our rehab team as well. We, as a rehab department, started socializing our tool among the nursing staff. And what I mean by that is we would go to the floors and during our rounds, we would report the AM-PAC score on the patient as we were rounding, hoping that, you know, the physician or the nurse would say, wait, what do you mean? What score is that? And that was an opportunity to socialize it, to get it out there, to start talking about it. We started that in March of 2018. And later that year in October, we actually started the proposal to ask for the AM-PAC licensing to be implemented in our electronic medical record. We got that going, and in November of 2018, the AM-PAC tool was finally approved at the system level. And that actually meant that all 11 hospitals within the Piedmont healthcare system approved using the AM-PAC tool as their new nursing admission screen. In January of 2019, we started the education to the frontline nursing staff. And again, rehab was instrumental in helping to get this education out because it's part of our rehab language, but it was new to nursing. And so we partnered with the unit-based educators on each of the floors. We created our own rehab AM-PAC traveling team that would go to the nurses' staff meetings. We would go to day shift and night shift. We had therapists who would come in early in the morning to catch those nurses getting off at night. And we would come in the evening as well. So once we educated the nurses, our AM-PAC tool as the admission nursing screening assessment went live on March the 25th, 2019. As you can see, this took over 2 years to implement, but it was possible. And one of our biggest selling points was, as Elizabeth had mentioned earlier, was we were trying to create that common language. So if I said a patient had an AM-PAC of 12, the physician, the nurses, the nursing techs, everyone knew 12 meant, ooh, they need a lot of help. And so that became our common language. And again, the nursing staff was very interested in it because after they completed the tool, they had direction on what to do with that score. Elizabeth talked earlier about what those scores meant as far as discharge destination and the guideline, but it also meant for the nurses that after they had done their assessment, if they scored a certain score, it would they were asked to generate a rehab consult for PT or OT. And it was 2 separate AM-PAC tools, 2 separate scores they would generate, and therefore the possibility of 2 separate consults. Our current state with our AM-PAC tool is we are asking, or the nursing staff is expected to complete the AM-PAC tool as their nursing assessment within the first 6 hours of the hospital's admission. And of course, this is across the system based on the score. And currently our threshold score is 21. So if they score a 21 or less during their nursing assessment, there is a best practice message that pops up, a best practice advisory that suggests to the nurse that they consult OT or PT or both, depending on the score. Once we get our consult, we go and complete the AM-PAC as part of our full comprehensive evaluation. The AM-PAC tool is used in that as well. And we also score the AM-PAC with every treatment session. We use the score as a guideline. It is just a score. It helps us direct the conversation to what is the best discharge destination based on that score. I want to emphasize that it's not a black and white score. If you score this, you must go to this destination, but it's just a guide. It helps the care managers, the physicians to actually start the conversation with families about the next step after hospitalization. Our future state is that we want to complete these AM-PAC scores, get the data, and use this data to help come up with possibly a different scoring threshold. And we're hoping that if we come to that conclusion and we come to a consensus that this is the scoring threshold that would generate an automatic consult. Right now, we are still relying on the nurses to take that extra step to enter a PT or an OT or both evaluations, a consult. And right now we are waiting, and we haven't currently established the timeline of when we want to complete that scoring threshold to make it automatic. But that is our future state and how we hope to use that data. These next slides, I want to show you how we actually are using some of the AM-PAC data to make some decisions. I know this slide is a little busy. This is generated from the Tableau software, and it is a Tableau report. This one is basically looking at nursing compliance. And when they are completing their nursing assessment and they complete the PT AM-PAC and the OT AM-PAC, how compliant are they? So when we proposed our presentation, this data was from last year up to January 2020. And this was about 4 months after we had gone live with our AM-PAC being the nursing assessment. So we used this data to see where we needed to go as far as nursing education. We were looking at the nursing score and the rehab score, looking for that inter-rater reliability, and also looking to see how much buy-in we were getting from the nursing staff and their compliance score. So if you look at the top of the screen at the PT AM-PAC and look at the grand total, the nurses were 94%, over 94% compliant, completing the AM-PAC for PT, and a little over 95% completing it for OT as well. So I think we got the buy-in from nursing that they were doing it pretty regularly as their nursing assessment. If you look to the right of the screen, and this is how we were comparing the nursing score to the rehab score. So the top one is, this is what the nurses completed and got an average AM-PAC score, and then they compared it to what our PT AM-PAC score. There was about a 3-point difference in that. So we were thinking, oh, you know, where is that difference lying? Where is it coming from? Is this a end user error? Is this, do we need more education? You know, we're trying to establish how much more education do they need so we can get these scores more closely together. Again, this was data back at the beginning of 2020, the beginning of the year. And since then, we have drilled down a little deeper and gotten our report to be a little bit more detailed. We went back and made some corrections. So on this particular report, we noticed that the AM-PAC score for nursing, PT and OT was based on the average number of AM-PAC scores they had done. And it was not the true number we wanted. We also did not include the difference in time between the scores, because the nursing score could have been completed on admission, but again, we were at the mercy of the nurse to enter the OT or PT order. And if they did not do it in a timely manner, we may have gotten the order 2 or 3 days after they were admitted, and their score at that time could have been 3 points different. So we're fixing that part of our report, but this is just one example of how we're using the data for the AM-PAC. Another way we use our data is, this is our rehab department summary and of compliance. So again, PT and OT, 6 months of data. We looked at how compliant were the physical therapist and the occupational therapist in completing the AM-PAC on their evaluations. And we also complete the AM-PAC on each treatment session, because we want to, one, show an improvement, but we also want to see if there has been a decline based on the treatment AM-PAC score. So you can see we were very compliant, over 95% to complete the AM-PAC on PT evals, and over 98% for OTs when they completed the AM-PAC on their evals. Our treatment compliance, every treatment, PT was at 87%, and OT, the grand total for the 6 months was over 93%. And one of the reasons that we looked at, why is there a lower compliance for treatment? And it could have been a few things. We looked at just user error. You know, the therapist just, oh, I skipped over that, I forgot. It could have been a learning curve for our new employees who did not realize, oh, I'm supposed to do it on the treatment one as well. And it could have been where an AM-PAC score was done on a previous session. That current session, the patient, for whatever reason, did not get out of bed, did not participate in their ADLs. So there was not enough task done to generate a score. So the therapist did not enter anything and assume that it was the same score as last time if they didn't see anything different because the patient didn't do anything. So there were some factors there that could answer why the score was lower. Well, we did as a department, make sure that we educated our staff to enter that score again, because of course the report generated the AM-PAC report off of a treatment. If you actually entered a number, if you billed for it but didn't enter a number, it affects your compliance. So we use this data as part of our rehab dashboard to help measure our staff's performance as well. We of course look at productivity, but we also look at the big picture of a therapist's day and everything that they are asked to do. And this is one of the line items that we will plan to use on our rehab dashboard for performance appraisals in the future. We also use this data to talk about where our patient population is falling. When we get consults for PT and OT, and we complete the AM-PAC on the evaluation, if you look at the grand total at the top for the PT, the patients that we were seeing that we scored between 6 and 17 was about 1/3 of the cases, and about 2/3 of the cases we scored them between an 18 and a 24. If you look at the OT, same area, their 6 to 18 score and their 19 to 24 score was about even. There's a difference in our cutoffs. For PT, the cutoff that guides whether they go to rehab is 17, and for OT, the cutoff is 18. So that's the differentiation in the scores. But it was interesting that for PT, 2/3 of our patients had higher scores. But when you go to the treatment part, after we evaluated and we treated these patients, the number of times that we treated them, every time we treated and we scored the AM-PAC, for PT, we were pretty evenly split, that we were seeing just as many patients who had the 6 to 17 score as the 18 to 24. But interestingly, the occupational therapists were seeing more of the low level AM-PAC scores and less for the 19 to 24. And we use this data so that we can help in the future decide where should our rehab resources be allocated. If we're going to have X number of therapists working and we have a caseload and we have patients that have 69% of our OT caseload has this AM-PAC score, we want to direct our resources to those patients who need more OT help. Same thing with PT. And so we've looked at both of these scenarios, and there is a case that can be made for both. In the acute care setting, if you were part of the last session, you kind of heard about our length of stay, and at Fayette, the average is a little over 4 days. COVID kind of changed that, but on average is about 4 days. And so we have patients that, for whatever social reasons, they cannot go to rehab. We have recommended that they go, but they cannot go. And so we have to make that decision. Do we, say for instance, on the PT side, we have someone who scores between an 18 and a 24, and the recommendation is, of course, guide them towards home and try to get them home, but they may not have the social circumstances at home that would make that a safe discharge. So we may allocate more resources to this person so that they don't have to go to a rehab and be able to go home safely. The same case is made for our patients who fall between the 6 and 17 score. They're going to rehab, but they may not have the funding. They may be there may not be a bed available, so that increases the length of stay. And so we reallocate our rehab resources to focus more on these patients with this score, so maybe we can get them home safely and not have to wait until a rehab bed is available or they have to stay here until they're safely able to go home, and we can get them home quickly. So this is another example of how we use the AM-PAC data at Fayette as well. The last slide I want to discuss and about how we use our data is this data kind of shows where our patients are being discharged home to. So you can see the grand total for the 6 months that we looked at data, the patients who scored between 6 and 17 who were discharged other than home, because that is the guideline, 17 and below for PT, we try to guide them more towards a rehab facility or LTAC. 58% of them were discharged other than home. So it begs the question of what happened to the other 41+%. They had a low score, but they went home anyway. Again, we look at the big picture. It's not black and white. We try to make sure that we are seeing the whole picture and the whole social situation. So just because they had that score, we're looking to see, is that their baseline? Would rehab benefit them? Are they able to make any functional gains in rehab as well? If you look at our AM-PAC score for PT between 18 and 24, and again for OT between 19 and 24, 91% and 87% of those patients were discharged home. That lines up with what our guidelines indicate, that those people who score that highly should go home with assistance or home with home health. Again, it's not black and white. There's a percentage, a little under 9%, that did not go home. They went to rehab. And again, this could be reflective of the big picture. They may have lived alone. They may have had a stroke, and even though they scored an 18 means they need some type of assistance, whether it's supervision or minimal assistance. They're at risk for falls and there's no one at home. So we sent them to the rehab route. But this is just an indication of where our patients were discharged to. And we're planning to use this data. For example, the patients who on the PT side who had a score of 6 to 17, the 41+% that went home, we are now looking at the readmission data to see and match what percentage of those patients that went home that we may have recommended that they go to a rehab came back within 30 days. So that we can use that information to either educate the family more, emphasize to the physicians more, whatever we need to do to make sure that this readmission rate is decreased and the patient does not come back. And as long as we have some data to support it, I think we will be listened to and more closely. So I just wanted to share that data, and next, we can look at some case studies of how we score and the different scenarios of how we come up with our scores.
Okay. So I'm going to go back because I think most of us, it's a little bit easier if we can actually see how we score. I kind of wanted to step back to all of rehab staff on our badge. We actually have this printed as one of our values in our badge. So we have it right there. So we actually can look and score it automatically when we first rolled this out when we were piloting within the department. As Lisa talked about on the timeline, as this has gone towards the nursing and all, they actually have a printed copy of this at our nurses station. And also the ones who participated in our roadshow, they actually got a copy of it for their badge too. So I think it's also that it is, once you get used to scoring it, it's very quick to do. But I think like anything, there's room for interpretation of how to score things. I think from the one that kind of got me first when I was learning about how to score the AM-PAC for the ADLs was, for example, the toileting. For example, if I have a patient who's, 50 years old and they have a colostomy, but they've been managing their colostomy by themselves, independently by themselves, well, that person, I would score that they are a 4. They're completely independent. However, a new colostomy, someone who has no idea how to empty, change the bag, anything like that, that is their tooling. So they would be scored a little bit lower. And I think that's just one example of how would you really score a person. And that's where you have to kind of know these guidelines of what category to kind of put. So that's where a little bit where the scoring can be a different. Like Lisa said, what we did as a department, we would take these different case studies and have a therapist score them, and we would have a discussion about where would we fall. So make sure therapists are scoring it themselves to make sure it's accurate. And then when we did the education for the nurses staff, we gave them an actual handout where, you know, where are these difficulties coming from? For example, the other one that came off a lot was if they're having a tube feeding. Well, they're not physically feeding themselves with eating their meals, so they would be deemed dependent on that. So if you do not know how to accurate score, if you give someone that they're dependent and they're really independent, it can definitely throw the score. What we also found was that people didn't understand the like min versus mod to max. So that's why we actually went to the where we have up top where we say unable, a lot, a little, none. And that's part of with the Boston AM-PAC, they use those terms also. So we felt like that was really important for our nurses too. A few examples for the mobility aspect. For example, I don't know about you guys, how many of your nurses actually take their patients up and down stairs? I can almost guarantee you it's about less than 1%. So that's where your clinical judgment for question 6, how would the person going up and down the stairs? You can use your clinical judgment. A lot of times with our nurses, we talk about how would they walk in the room and kind of to use that as a way to help guide you with climbing the stairs. Again, I kind of mentioned beginning because we actually really went back to the literature when we were learning how to score the AM-PAC ourselves about how does the assistive devices use, because any of us, if you ask a therapist, if they're using a walker, what would you score them? Well, most of us would say mod I, but they do have that device. So based on the scoring, based on the Boston University, they have said that would be deemed a 4. They are independent. So our next slide is just our references that we have pulled for everyone to see. So I'm going to exit out of this and stop sharing my screen. Thank you for everyone putting the chat option up. So that concludes our formal aspects of our presentations for you. Oh, I just read this.
You have a lot of discussion, but a lot of it is talking about the data and just kind of getting in on your image. And then from that, just general comments about, like to your point, the staffing and the RNs being able to do stairs would be not common practice.
Gotcha. Sorry about not having the data where everyone could see it. We thought you'd be able to see it.
I think it depends on the device. I could see it pretty well. I think the way that you guys promoted your introducing this tool was brilliant, like starting to just do it on the floors and at a very grassroots level for buy-in. That's great.
Yes, and we asked our rehab team to just volunteer, and in our hospital, we rotate through geographical areas. And so we had the same therapist on the same floor, and they were very familiar with the nursing staff and the nursing techs, the patient care technicians. And anytime they would be in the room with the patient and the nurse came in or the patient care technician came in, they actually would just start talking about it and just say, I'm about to get this person up. There's a tool that's coming down the pike. So if you hear me talk about, oh, this person can get up to the bedside commode because they were an AM-PAC of 18, they were encouraging the nursing staff to feel comfortable. And so we got them to, even if they were not scoring yet, we wanted them to understand the numbers. And the way we communicated with them is in the room, we would treat the patient, evaluate the patient, but we would communicate to the nursing staff how this person moves by writing on their whiteboard. And if we put AM-PAC of 19, the nursing staff and the PCTs automatically felt comfortable. 19, oh, I can do that by myself. If they had seen a AM-PAC of 7, then they knew to go get help, that don't try this by yourself, go get some equipment. And that was their way of feeling comfortable about moving a patient and having some idea of what to expect. But that worked very well because the nurses felt comfortable with the therapist. And again, in rounds, we just took the initiative to just report that as part of our rounding too. And again, hoping that someone would say, wait, hold up, what is that? And that was an opportunity to socialize it as well.
To answer one, if anything, what did you use before this? So kind of to step back. So nursing on a mission had a 26 questions they were required to ask of each and every person. Some of it did not pertain to like ADLs or mobility, but it was what they had to do for their inclusion criteria. So when the idea of the AM-PAC as this common language came about, we went to our nursing board, say, hey, this is what we're kind of seeing. We got the buy-in from them very quickly. And that's why it took so long to get the approval for it, because it had to go through many steps. Yes, this is what we need in the mission. Yes, there are still some more questions about like medication. Also, this is just one part of it. But in essence, it narrowed the part of 26 questions they had to do down to these 12 questions. One thing I would kind of mention too, there really was not that communication before about ADLs and mobility. I think like most of y'all, sometimes you didn't have any information of what the person could or could not do till you went into the room and you started talking to them. And hopefully sometimes we had a family member or caregivers, but sometimes you didn't do to figure out like what that person needed to be. So this was a way that we felt that we could include what we were looking at, but also the nurses could do. I think the other thing is like we had to get buy-in for the upper leadership. They had to see it. And that's why we felt that we needed to include these numbers in here for you guys. So you see that we had 95% over the averages of those 6 months, a buy-in from the nurses. Now, yes, that is the data of the patients that were admitted to the hospital, but rehab services were also seen. So obviously that's not our total population. But that was just one way we could measure it. Because like Lisa said, we actually had to go through Boston University to get the licensing for the AM-PAC tool. Because when we first started using it, we were just free texting it in our notes what their score was as it predicted to our discharge location. So it was just one of the tools we were using it. As we got that buy-in saying, yes, we could do it, now is automatically, we use the documentation system of Epic. It is actually questions that come up on the flow sheets for nursing staff to answer each individually. So is that what you were asking with that question?
Yeah, and the second question we have in there is, what impact do you think the lack of a cognitive piece has on the validity of the assessment?
So with the cognition aspect, that's why there's a third branch of the cognition. And that's where, like I said, speech had a major play with that. Some of the assessments they were using, they felt were a stronger assessment versus the AM-PAC cognition. And also there was not directly other than cognition being within normal limits or impaired. That was pretty much the screening that nursing were completing for each patient. It didn't break it down anymore into cognition.
Can I follow up on that a little bit more?
Yes, ma'am.
How are you doing, Elizabeth? It's good to see you doing this stuff. I'm going to put my video on so you can see. So I know from my own experience, though, that a big variable in all of this stuff is the person's cognitive ability. I mean, they can be very physically able, but their ability to be home is just depends tremendously on their cognitive stuff. So I'm just wondering from a clinical judgment perspective from both of you all, how much do you think that is, negatively impacting the validity of this assessment? Because you're really only using 2 legs of the stool. You're not using all 3. And I hear what you're saying about speech and all that, but I would be kind of curious to see what would happen if you went ahead and did the 3rd one to see if it would improve the degree to which you could accurately predict where people needed to be. And it
Yeah.
doesn't sound like it's that hard, like it has to be, you know what I mean? It's like they got a problem or not,
Right, right. And I think from a rehab perspective, I mean, from a PT perspective, we are looking at that big picture, even though we may not have done the formal cognitive assessment.
Right, of course you are.
But we are looking at the big picture, like
does the guy like his brakes or not, and can he remember?
exactly. It's like
It's the world's most basic cognitive assessment.
exactly like this person can walk okay with the walker, but cognitively he's never going to pick it up and use it. He's just not going to remember it, and so he's just not a safe discharge home. So no, we don't have that cognitive piece, but I think we just look at the big picture from what we're seeing and their safety assessment, their ability to answer questions and follow commands, and just incorporate that in the big picture.
Well, and I don't mean to be disrespectful from the speech therapists, but they actually don't own cognition. I mean, and so I guess I would encourage you to give it a shot with you guys doing the cognitive piece in nursing and see if it improves the discharge. You know what I mean? It's just data. And I know we all get caught up in politics, and I've been there, but I've also been there before speech had cognition. Back in the day, they didn't. Back in the 70s.
I
fact,
have
I
personally.
go so far back as to when PT had swallowing, if you want a real history lesson. So this stuff moves around is my point, and it seems like a really lovely little tool that that you all have come across. So I would really encourage you to go ahead and use the cognitive piece, whether speech is happy with it or not, and see if it gives you better information.
All right.
Yeah. And Dr. Shell, like sometimes as with OT, we do use it, but more of when I feel like it's appropriate for the patient with the questions is what I do. So thank you, Dr. Shell.
Yeah, okay, thank you.
Just to kind of add, because Miss Elizabeth actually put in here, she is with Emory St. Joseph, that the same thing that what her speech therapists were also saying with the assessment part. I do think we've come a very long way in this whole process of getting it introduced. Is it a perfect situation? Absolutely not. Are we continuously having to do that education? Just like we have different staff leave the rehab department, so is nursing. So that's been one of a big barrier for us to kind of make sure this stays on the forefront. As we kind of talked in our last presentation, COVID's kind of in the forefront of everyone's mind right now, but we've also had to keep this dialogue going because we've come so far and we don't want to lose that aspect and the momentum we have going with this. I kind of mentioned it before. One of the things that we really pushed for is, and I can share my screen one more time, is, oh no, can you actually can see without me sharing. Let me do it this way. Kristen, how do I cancel this?
To cancel the screen share or to cancel?
Yeah.
You should be able to just click out of it because I don't think you fully shared yet.
Oh, I found it. Can you see my screen still? Like we do in our badge, we have the picture. So that way we always have it on hand with us. We have the PT and the OT side. And we've had, even like when we've given this out to some of the nurses who've been very involved in it, it's definitely been a great conversation piece because they want to share with us. We have, especially on our cardio stroke unit, we have actually, it is a section on the rounds form. So each nurse actually will state their patients, PT AM-PAC and OT AM-PAC in rounds. So just kind of another way we kind of include it with that way. And our physicians actually love it because it gives them direct data to go to the family members to kind of help objectively say why we're recommending rehab or, which services we're recommending. as a great conversation. So we've actually had great feedback because we have done information sessions with our physicians too.
And we have a fresh question in the chat box, and it states, any concerns with nursing also using it? That we are then able to justify the skill and the billing for our use. I think it's great that for all of us to be on the same page and that we're working to do this too, but I'm just wondering if this has ever been brought up.
So I would take it, and Lisa definitely jump in with your opinion too, that this is just one part that I bill in my evaluation. Like I said, we typically try to do 2 standardized assessment in each one of our evaluation. So this is just one tool that's being used. The one step I would take it further from an OTPT side is that we are, there's actually a correlation % deficit. So that deficit, for example, if you score a 12, is roughly that you're a 50% deficit. I would hope my scoring of my ADLs would be about that 50% level so that it is a check and balance. So nursing would not be using that % of deficit. This is how I would justify that question to a biller.
I think too, to kind of what Barbara was saying, if we're using measures that overlap with other individuals' disciplines, it's also a great way of justifying referral to that discipline. Maybe speech therapy hasn't been brought on, but now we can demonstrate with this assessment tool that there is a deficit, and can we get that service included? A lot of times I think if we're all practicing to the highest level of our licensure, there really isn't the need to feel threatened, and making sure that that becomes part of the norm of the interactions with our peers is really important, because we value their input too, but we do have the capacity to cover some of those basics and to recognize when we need a referral.
Well, I guess my other thing is that this tool, nobody's suggesting this tool is a detailed an assessment. It's not an OT assessment or a PT assessment or a speech assessment in any depth. It's a screener, but it sounds like a really handy screener. And so that's why I'm like, use all parts of it, and then do what you said, Kristen. I mean, send it to speech if they've got some stuff, or if their cognitive stuff may be very blended within their ADL stuff, and then send it to OT, or neuropsych or whatever. But it just seems really like a handy little tool you got going there, and I hate to see you only use 2/3 of it, because my bet is the power of the validity of the tool involves all 3.
Yeah, it's been kind of interesting as we've been preparing. When Lisa and our director Jill was introducing this to us, like what they were bringing back, it was kind of interesting, because I do think some of it is where we are in our professional career. For example, I was brought into the OT world of the importance of standardized tools and why we need to use evidence-based. And I think with the AM-PAC, for me, who was research-based, going and seeing the research that was completed on it. So I think you're absolutely right, Dr. Shaw, about the importance of it. And I think it's a tool in our toolbox, but it's not our entire assessment.
No, it's not. Yeah.
And I think that's where it kind of helps. Like I can, even with my conversations with my COTAs, because with using the tool, if I score someone an 18, I'm recommending they're going home, and then my COTA goes in a day later and they almost get where they're a max assist with most of the ADLs, and they're like, Elizabeth, this person scored a 9. So what we actually have set up with our COTA as a dialogue, if someone has a change of greater than 5 points, the OT needs to go see that person. Figure out what is the change and why. Now, sometimes it is as easy as someone had surgery and they're still under the effect of anesthesia, but it's
or meds or whatever.
Absolutely, it's bridging that gap. So we have actually been able to catch some people where I've originally recommended going home, but you know what? 2 days in bed, they need rehab now. So it actually helped us decrease our length of stay in that point, because the COTA caught that there was a change in status in this patient, using the AM-PAC and their clinical skills with their ADLs to say, hey, we need a reassessment. And a lot of times, honestly, those COTAs and PTA, I'm sure you can speak on that, Lisa, too. The PTAs will definitely say, hey, something's not right. Y'all need to go in there and reassess them. And honestly, we have caught some people from going home and also some major medical issues. Like I can think of one where it's like a PE. Like we actually caught the PE because the patient could not, honestly, it took everything out of them to even stand. That person caught it. So we based on the change of status, it was one of the tools that we definitely escalated it up for sure.
It's just such a huge improvement over the deal, and at least I'm sure you can relate to this of, well, they can walk 100 whatevers, and so they're ready to go home. You know, I mean,
most definitely, most
you
definitely.
know,
Yeah,
I mean, I'm just like, hallelujah. We got
Yeah.
a new standard.
yeah. And we also, I mean, I also found it interesting too, that we got a lot of buy-in from our acute rehab facilities as well, because they have to come in and do their assessment to see if this person is appropriate for rehab. And they had no idea what the AM-PAC was and what does this score mean. So for them to come in and see, this is why we're recommending this. And of course, we are still, aware of that. I need you to only walk, 99 feet so you can go to rehab. Don't stop right here at 99 feet. But they also were appreciative.
Don't you have to go to the bathroom, right?
Exactly. And so I think our AM-PAC tool has become common language among our rehab facilities, our acute rehab facilities as well. So it is just another tool in the toolbox. And I think it is, we've used it in so many ways. I think we even, some of our PT goals is to, one of them is to increase the AM-PAC score by 4 points. Because
It's measurable.
it's measurable, and our research has shown, that a 4-point increase does show some effectiveness in your treatment. So if we are just using that AM-PAC score as a measurable goal, then we're just using it in all types of ways that we're very happy with.
And also with our sister hospitals, like for example, the question came in for other discussion was a patient leaves our facility. We don't do ECMO here at our hospital, but our Atlanta hospital does. So a patient that might discharge from us, go up to Atlanta, come back, we can actually trend their AM-PAC score to see how they're progressing or how they're declining. Also, we have, I'm sure like most of y'all, repeat patients who come to our hospital because we are a community hospital, and we can kind of track those trends. So what we like about the fact that it's included in our documentation system now in Epic, we can actually pull these numbers that Lisa was talking about. So we do have these reports, so we can go back to our executive staff, who there are a number of people, they need to see why we're doing, why do we need therapy, the justification for our services too. But it's just one more tool that we can use. Hey, we have a measurable outcome. So. Kristen, are we missing anything? Because you're doing a good job with our questions. Does anyone have does any other facility use? I know Miss Elizabeth had mentioned some about their speech therapy. Does anyone else use the AM-PAC? Or before this, had you been aware of the AM-PAC? Oh, this is so hard not to be. Let's see. And that was my guess. Tell me what AU stands for again.
Augusta University. Is that it? Yeah.
Okay. Because I know we have, I don't know if Dr. Shotwell, I know she's also with the university. I don't think she's on here anymore. I'd be kind of interested to see, is school, I know, for example, I'm not that out of school that far from my doctorate in 14. This was not something that was introduced in my OT schooling. So I think it's something also that to educate our younger therapists coming in, because now when we have, especially our new grads coming in our department, this is common language. You do this on your evals and your treatments. So that way we do have this projection of how the scores are going.
So you ought to give Kay Graham a call and no, I'm serious. And tell her and let her know what you guys have been doing. Because I think she's I'm not sure who's doing the acute care stuff at Grinnell, but it would be worth calling them and seeing.
Oh, and then let's see, someone teaches us. I teach assessment documentation, have not taught it before. Well, I would be happy to be a guest speaker if you'd like me to be. AM-PAC is kind of becoming my world. So sorry, our lights haven't been moving enough.
Oh, okay.
There we go.
The other comment was that Elizabeth uses it all the time to justify G codes. And then your Lauren here, or Lori went ahead and put her email in the chat box to connect.
So again, I think everyone can kind of see the usefulness, and I think Shell kind of brought up a good point that, you know, it is, you know, really just one tool, but, you know, our core as OT and PTs too, you can see the collaboration effect. I think one thing that Lisa kind of brought up kind of briefly, someone might have a deficit in the mobility, but be completely independent ADLs, or vice versa. I think, for example, the condition that comes to my mind is like a shoulder injury. Their ADLs are completely different because of restriction on their shoulder, but their mobility. So that's where having the separate scoring, hopefully PT would not get triggered as an automatic. I hope they would still mark their mobilities independent, but it's their ADLs. So that kind of is something we kind of have to make sure people are aware of our services too. I know one question that was brought up from our sister hospitals when we're trying to get this automatic referral. I don't know the rest of you guys in acute care. I've seen a change recently because they're trying to get patients out the door a little bit faster, but sometimes a patient would be here for a week and they haven't gotten out of bed and they're wanting to send this patient home. They literally can't stand and walk anymore. So this is another tool that when we promote it to our executive board to help with that length stay, reducing hospital readmissions. That's real. When you start talking money and how it makes a difference, we get a lot more buy-in. So
Yes.
Definitely. And I guess Barbara's comment is a really great one, which is this is a really good example of using data to help folks work together in the best interest of the patient. And I think that really does sum it up.
Yeah, yeah. That's great.
I mean, it's actually, and that's why we felt very passionate about presenting this conference to let other people know, because honestly, it started with one person attending a conference and where it has impacted our hospital at Fayette, but also all of our Piedmonts now. We have this tool in our documentation, and anyone who works for a system, you realize how long does it take to bring change. And I think this is a perfect example of how we can make a difference as a therapist on a system level. And that's why I put, can you tell he used to be a professor of mine? To see the big picture of really how we do impact not only that one patient every day, but for patients to come, and how really it takes the time to say, hey, I have this idea, because I can't even point in how many thousands of hours been built in from our director or leadership to allow us to even do the education to provide to our nursing staff. And it really has made a difference. So
I think that is so important that you included that slide about your timeline, because I think we all come out of school with so much excitement and we think we're going to, you know, have a big splash, but sometimes it takes a lot of dripping before we can fill the bucket to then pour into other people's cups.
Exactly. Yeah, that was an eye-opening experience for me as well. Being part of a system, and you know, Piedmont having 11 hospitals, I'm used to my own little Piedmont Fayette world, and I just have to make a suggestion, and it only has to be approved by one person, my director. And then to get this as part of the system level, and the politics of getting on somebody's agenda. I'm like, oh my God. I mean, what do we need to bring? Do we need to bring bagels? I mean, I just want to talk to you, you know, and it took 2 years, but it paid off in the end. And I think all of what we're seeing now from a rehab perspective is the initial hesitation from our nursing leadership, because again, they did not want to put one more thing on their nurses' plates. Now we're seeing the buy-in from nursing leadership that they are really big on AM-PAC now, and they are encouraging us to make sure their nurses are very well educated and making sure their nurses have the opportunities to learn as well. So it was a neat experience.
Yeah, effective communication will save everybody time in the end. And you have a couple of comments in the chat box, and it's Kaiser's wanting us to use it as a demo to progress and justify our discharge recommendations now. And then, and still she persisted.
But we just want to say, as we're wrapping up, thank y'all so much for staying on. I know it's kind of late and we've had a crazy day with the weather, so we really appreciate it. I know the handouts, especially for people who could not see a slide, I apologize completely. But the handout will be provided. I'm not sure how Tiffany is sending out the handouts, but it has been included that we submitted. The other thing is make sure you complete the course questionnaire at the end so you do get your certificate for attending. And thank y'all for being so patient as we learn this new platform. We thought we were going to be in person, so technology is, something always challenging, but thank y'all so much for making this an easier experience for us.
And thank you all. This was my first OT conference, so I am very excited and it was fun. Thank you very much.
Well, you did a great job. Welcome aboard.
Thank you.